Hi, my name is RRobinson, and I am an occupational therapist currently practicing in the skilled nursing facility setting with the geriatric population. Um, I am undergoing the coursework for Master of Health Science curriculum with the track of data analytics. Today I'm going to present to you on the topic of group intervention strategy for post-fall elderly patients. Within this presentation today, I'm going to review the problem in the PICO question, the evidence, Borough Exchange model, database evaluation, plans for dissemination, and conclusions. So the practice problem that I was able to identify in my current work setting was that individuals who sustained a fall often resulted in the onset of depressive symptoms. And these individuals in which I typically work with are those who are 65 and older. And the research is showing that 30% of these people that are 65 and older suffer a fall each year. And 11% of those individuals are referred to rehab services for a continuation of care. And anywhere from 1/3 to 1/2 exhibit the symptomatic depression symptoms during their hospitalization course. And this is really a significant ordeal because as a rehab clinician, when an individual is presenting with these particular symptoms, it affects the discharge planning, their rehab course, and how they perceive with their current situation. And these symptoms um, may have been brought on, one, by this traumatic injury of this fall, number two, for being in the hospital for a long course, and then number three, being away from their typical home environment, which leads to the biological, the psychological, and behavioral factors that result in these negative consequences impacting their recovery process and their quality of life. And unfortunately for the clinicians and their families, creates a challenge for discharge planning of these individuals. Families are concerned that their motivation levels are so low and they're not making this progress. They are left with the dilemma of, should they just go home and maybe they will see an improved function, or should they already determine discharging to a long-term care setting? So this is the current problem that we're currently faced with at this time. And so as clinicians, we were recently faced with implementing group treatment back into our plan of care. And so clinicians were also faced with trying to find the best practices for group treatment for these individuals. And so what I'd like to do, or this research, is to help identify what are the best group treatments for these patients that will lead to improved outcomes and outcome measures that are obtained from the clinicians on admission and evaluation, discharge evaluations. So the PICO question that really kind of came together for me was, are these elderly patients who are status post-fall at an increased risk for the onset of depressive symptoms to impact functional performance outcomes when participating in a usual occupational therapy intervention versus a combined cognitive behavioral group intervention within a 30-day skilled nursing facility stay? So the keywords that I was able to explore to obtain a more lucrative search strategy included depressive symptoms and hip fracture. This topic is pretty inclusive, so it was limited to the older individual, which was 65 and older. So additional limits included being within the last 5 years. So the dates were from January 1st, 2015 to December 31st, 2020. The information was limited to articles written in the English language, as well as being specific to the hip fracture. So exclusion criteria for this topic included diagnoses that included the head trauma, other joint fractures, rheumatoid arthritis, neuromuscular disorders, progressive dementia, or other advanced cognitive disorders. Studies were particularly included the hip fracture involved those who received surgical intervention or conservative treatment. If they did receive a surgical intervention, it was either an ORIF, an open reduction internal fixation, or a hemiarthroplasty, which is a hip replacement. The databases used for this literature search included the University of St. Augustine USA database. It was pretty lucrative for me, as well as PubMed, and OT Search and Pedro databases were used as well. Here is my Prisma diagram showing the process of my literature search. As you can see, the Search USA was pretty lucrative by providing 3,313 citations. PubMed provided 2 citations, and the other 2 databases, which include OT Search and Pedro, were not as lucrative because the information was not within my date range of the inclusion criteria or as well. So all in all, I was able to retrieve 63 articles, which I was able to extract or exclude 50 and then additional 5 because they did not meet the inclusion criteria. So I was left with 12 remaining articles. 9 of them were primary research and 3 were systematic reviews. The conclusion from the evidence that I was able to extract was that the onset of these depressive symptoms were truly related to the biopsychosocial factors, that the increase of pain also led to increased emotions. The degree of individuals' fragility and their level of comorbidities and their frailty of age also impacted the onset of depression. And those who had pre-existing depression were also more likely to have an onset or occurrence of depression. All of these symptoms were an impact on their rehabilitation course. Those who fit in these categories had a decrease in progress for their mobility, their balance, their ADL skills, and which negatively affected their rehab course. Also, the interventions. In regards to interventions found, the traditional occupational therapy interventions were educational training sessions as well as provided exercise, which only had minimal effects on improving the onset of depression and alleviating some of these symptoms, whereas those who participated in the cognitive behavioral group therapy interventions in combination with their traditional rehab treatments had a more positive effects on their overall outcome. There was a decrease in isolation feelings. They were able to talk to other people. They had a positive improvement in their strength, mobility measures. So these individuals definitely had a had the positive benefits over the more traditional therapy intervention, therefore leading to these positive functional performance and an improvement in their social disposition, leading to better quality of life for these individuals. So the Burke change model is the model that I have chosen for implementing this change. So the reason I did choose this model was it is an evolutionary process. This model definitely shows that. So as you implement a plan, at each point you're getting that feedback and seeing how the individuals are performing within this new change model, and you just kind of adapt and do as you move along. And I feel like within the rehab setting, we're constantly adapting to the clients that we're meeting, and so this definitely provided a valid explanation of how to implement this protocol and make sure it is the most beneficial for the clients that we are working with. So the data collection process that I am proposing here includes the initial qualification inclusion criteria. These individuals will need to complete the mini mental status examination, and within this examination they need to achieve a score of 13 or higher. A score of 23 is typically not associated with any dementia. However, this population tends to have several other comorbidities, so a score of 13 is acceptable. Also, collection of their socio-demographic information, including their age, their sex, their fracture, and type of surgical intervention they may have undergone as well. As part of the actual collection, the clinicians will evaluate the individuals at admission and also at discharge. The particular outcomes that we are looking at here for this particular study will include their degree of depression, as in mild, moderate, or severe, in relation to their injury, and their degree or level of assistance that is required for their functional performance outcomes, in particular their mobility status, their ADL functions as well. That data collection tools to collect this information will be the geriatric depression scale and the modified Barthel index. These two have been widely used in research and will provide a wealth of information regarding this population. The proposed study design here is a prospective random control trial involving a group intervention with cognitive behavioral group therapy group, as well as the traditional occupational therapy group intervention. So those are the two intervention groups. These individuals that will participate in the group intervention will have an opportunity to interact with their peers and the other clients as well, to discuss reasons of falling, their fears of falling, and strategies that that can prevent falls. So this should be a reinforcement of their traditional occupational therapy training that they are getting. These individuals will participate in a group once a week for about 25 minutes, and there will be about anywhere from 4 to 6 individuals in each of the groups. The duration of the stay for these individuals is about 2 weeks to 30 days. So we're looking at potentially a 30-day stay to obtain the follow-up assessment. The evaluations here to analyze the information will include the chi-square analysis to achieve the descriptive statistics of mean, median, mode, as well as the Wilcoxon signed rank test. And this test in particular will help identify the differences between the baseline and post-test measures in the same group of individuals from each intervention group. The test also to determine if there's a difference between the two treatment groups will be the Mann-Whitney rank sum test. And in order to determine if there's a correlation between the two variables of the geriatric depression scale and the modified Barthel index, the Spearman rank correlation will be completed. Plans for dissemination for this group intervention will be the Bridgemore facility. This organization is made up of 5 facilities, so therefore the implementation of this type of treatment strategy has an opportunity to be assessed and evaluated by the clinicians. And so I'd like to get ample feedback on this population before plans to disseminate at the Gulf Coast East Regional District meeting, and therefore I can get feedback from the presentation from other clinicians who may work in this particular setting. And eventually I'd like to do at least a poster presentation or even a general presentation at TOTA or AOTA, and plans for publication once all the data is collected would be in the American Journal of Occupational Therapy or the Occupational Therapy Journal of Research. So my recommendations here is that we do know that traumatic fall events within this population are at risk for the onset of depression. And it's very important that we recognize these symptoms early to address their psychosocial needs and to implement the best practice such as cognitive behavioral group therapy intervention as a strategy for addressing their psychosocial needs. These cognitive-based intervention end up being a tool for this population and definitely can aid in their as a comprehensive part of a rehabilitation program to address their needs. And these strategies serve as a platform that reinforce patient education and increase awareness and insight. More importantly, these individuals will gain psychosocial benefits of increased confidence and self-efficacy and reduce the fear of falling, lessening their onset of depression. Today, you were able to hear the problem in PICO question, the evidence, the change model that is to be used to implement this strategy, data-based evaluations, and plans for dissemination. Here are my references on these last 2 slides. And if you have any questions, I greatly appreciate your feedback. Thank you so much.